Today, we are hearing from two experts at different levels of care. We're hearing from Karen and Christine, and we are going to talk about children, youth, and young adults crisis care access. And I am so excited to introduce you to our panelists today.
Sure. Good afternoon, everybody. I am Karen Maher. I am a clinical director in Santa Clara County, and I work with an agency, Pacific Clinics. Some of you that are local to the Bay Area might have known us as Uplift Family Services. We recently went through a merger with Pacific Clinics, which is predominantly in Southern California. So we've adopted our new name. And I oversee what's called the crisis continuum of service. And what that is a crisis response model for children and adolescents. And it's based on the SAMHSA model for crisis stabilization. So the front end of our program is a crisis response hotline, and then a mobile crisis response team. So we can respond anywhere in Santa Clara County. We're a non-law enforcement partnered program, so we don't do any sort of joint responses. Mm-hmm. We're responding to crisis independently. We go in groups of 2. And then the second component of our program is what we call the crisis stabilization unit, which is a 23-hour, 59-minute stabilization unit. And really the goal of all of the continuum is hospital diversion. So we really use that 23 hours and 59 minutes to work with the children, the families, to see if we can avoid having the children go on to an inpatient hospitalization. I will add the caveat that program is an LPS designated facility. So that facility is for children that have been placed on a hold. Okay. So like a 72-hour involuntary psychiatric hold. And then the third one is what we call our post-crisis stabilization services. So that's an outpatient aftercare program that includes therapy, rehab services, and psychiatry. So it's a 3-component program where we really work to stabilize kiddos and avoid hospitalizations.
So the reason I'm so excited that we have you and Chris together is because we're getting a look at we're going to zoom out, and Chris has a really interesting role at a systems level. So Chris, I'm going to let you introduce yourself. Who are you in this work? Why are you in this work? And what connects you to this topic?
Hi, everyone. I'm Chris Stoner-Mertz. I'm the CEO of the California Alliance of Child and Family Services. We are an association that represents 160 nonprofit community-based organizations, of which Pacific Clinics is one. And my own background, I am a licensed clinical social worker and have actually been doing work as a provider until the last 3 years when I took this role on. So our primary efforts are to ensure that our member organizations have the policy and advocacy attention needed to ensure that their services are high quality, funded well, and that regulatory supports are in place across the state of California. So I'm really excited to be here and talk about this critical issue in California and really across the nation for kids.
So Karen, first, starting at the program level, from your role and from your lens, how has the COVID-19 pandemic, wildfires, or other disasters impacted your programs and or the people you serve?
What a great and complicated question. The simple fact is we've seen a significant impact on our children and families, but that impact has been complex. COVID-19, we really saw the children and families go through cycles. When we had the initial shelter in place, a lot of our referrals come from schools. So in the first few months of COVID, we actually saw a really significant drop in our needs for crisis response. And we attributed that to a lot less eyes on the children, simply because our biggest referral source during the day was the schools. And then what we started to see as the shelter in place and the restrictions and the transition to online learning, what we saw is a pretty consistent increase in the need for crisis response in the late afternoons and into the evenings. Historically, our evenings are somewhat slower, but what we really saw through the shelter in place orders was a lot of need for crisis response, afternoons, evenings, and even into the overnights. We saw a lot of children that started to have sleep pattern disruptions. And so it was really interesting to see. Usually we'll get 1 or 2 or 3 needs for in-person responses on what we call our knock shift. But we were starting to see weekly needs for crisis stabilization in our communities, 12 a.m., 1 a.m., 2 a.m., which was a pretty significant change. The other issue that we've been navigating most recently with the community violence, and I shared this with you before we jumped online, but I'll share it with the rest of the group. That day after the school shooting in Texas, we generally serve a pretty small amount of children under the age of 12. We usually sit around 1 child a month, maybe 2 children a quarter. But that week after that school shooting, we saw a 50% increase in children under the age of 12 that we were responding to either at schools or that were placed on holds and brought to our crisis unit. So, what we're seeing is our kiddos are so sensitive to what is going on in the communities, and that, their little central nervous systems, when there are those traumatic events, those environmental traumatic events, their little systems are just reacting to it.
Oh, Karen, that was so, what you said about the time of day difference brought me back to like the overwhelm as a school employee of having to plan out my day by, if I knew I was going to have to contact a crisis team, I was definitely like, if it was after 10:30 a.m., I was like, I got to do something different because they won't get here before school will get out. So as soon as you said that, I was like, ding, I bet it's mom and dad calling when they get home from work instead of a school employee calling during the day.
Yep.
Chris, I'm going to throw the same question to you and ask what were the challenges that you've seen over the course of the pandemic or specific to your state from that systems perspective?
Yeah, thanks. Zooming out and the examples Karen gave are so reflective, I think, of what we've seen across the state. And unfortunately, not every region has the kinds of supports that Pacific Clinics is giving, in Santa Clara County in particular. But so we've seen significant increases in children that end up in emergency rooms because they don't have that sort of initial phone call that can help support not just the child, but also the family members. Excuse me. And of course, our families who are essential workers, who are low income, really struggling, not just with, what we think of as traditional mental health issues, but with all of those issues related to access to resources and services, to the LGBTQ youth who, already probably felt often othered, but under a pandemic situation and with some of the other climate issues going on. I mean, there's just so many things that they have had to deal with on multiple different levels. And we've really seen that we don't have all the right resources. We've seen the real gaps and the disproportionality in access to services, but we've also seen how important it is to coordinate care. And I know we're going to talk a little bit about that, going forward, like how do these organizations and counties and government entities work together? So many opportunities to see where we need to keep working on things. Yeah.
I really like the way that you phrased that, Chris, the opportunities to see where we can build bridges. I mean, what I think I heard from the thread line, there we go, what I'm looking for, that during COVID-19 and with everything that came with that, the nature of needs changed. The demographic of who was calling and in need changed. The way we responded changed. Karen, like when you talked about the time of day, that would greatly inform my recruitment and hiring practices. And it would just change the demographic of how I staffed my agency. And then also the severity and duration, while it might not have looked the same as pre-COVID times, because the severity had spiked up so much, even if the duration was more brief, it still required like this different type of response with less supportive adults in the picture because schools were closed.
Yeah.
Oh, that's interesting.
Yes, it's interesting you bring up the intensity. The other trend that we saw throughout the pandemic was an increase in actual suicide attempts, and most were tied to overdose. I mean, we didn't even have to run data in our, from our electronic health record to see that we had such an increase in children that were coming in from emergency departments because of overdose, whether it was a suicidal attempt or they were self-medicating at home, and it was an accidental overdose. But that was another trend that we saw through the pandemic for sure.
But this is the reality of what we're confronting, right, Karen? The need has changed, the intensity has changed, and the way we need to approach it has changed. And the other thread line I think I heard, and I'm hoping we can transition to this because I think you both have some really good strategies to share, is that we need a fundamental restructuring of how we address care at different levels of intensity that are not just crisis. So if you joined us this morning, those earlier levels of support. So Karen, as a crisis care program that provides services to children, youth, and young adults, working with families and caregivers is guaranteed. Kids live at home. How does your program foster relationships with family members and caregivers to aid treatment goals and increase engagement and use of natural supports?
Yeah, it's such a fundamental part of our service. We include family members and natural supports from the first phone call. It's part of why we send our clinicians out into the field in teams. And sometimes we send 3 if there's a need, because a lot of times the families need, the parents, the caregivers need as much support as the client that's going through the crisis. And sometimes we don't even like to say like the client that's going through the crisis, because really it's the family that's going through the crisis. And that could be, mom, dad, caregiver, brother, sister. Mental health crisis in those moments can be traumatic for the whole system. So that's the approach that we take. For our children that come into the crisis unit, we have a process. We call it like a family meeting or a child and family team meeting, where we're inviting the caregiver into the unit to be able to provide them their own emotional first aid. A lot of times when children get put on holds, there's a lot of staff that are supporting and coaching the child and giving them that emotional first aid. And then it's an hour or 2 hours later that the parents arrive and they're still experiencing their own crisis, their own dysregulation. So It's something we always try to do, whether it's on the phone or in person, that we're spending the time with the caregiver to support them in moving through that initial kind of crisis phase, getting themselves, back regulated. Is it a cup of tea? Is it, just having a conversation and having space to vent before we move into any assessment or, the technical stuff that we have to get done in this work. It's spending the time to engage and connect, provide hope. And sometimes it's just explaining what's going on. I mean, if you really just stop and think about it, your child is being taken from you after a mental health crisis. I mean, it can't get much scarier than that for a parent or caregiver. So part of what we do, like I said, is build it into our philosophy for how we provide services. And then we also do, in our safety planning process, we always do like a plan for children, a plan for the caregiver, and then a plan for the family. So, when you think
That's
about
cool.
traditional safety planning, you always kind of think about like this, I call it the old school way of like, how is the child going to be safe? What are their coping skills that they're going to use?
And they give the same list of mental health hotlines that everybody's seen a bazillion times and no one's actually going to use.
I'm gonna listen to music. I'm gonna read my book. I'm gonna call the hotline. You're absolutely right. But we have to start to think about like, what are the different components of the family system? So, how do we support the caregiver who's gonna be, tending to this child's needs? How do we help them understand, what the triggers are, what are the unmet needs for this young person, and how can the caregiver meet those needs? What are the caregivers' needs? What sorts of stressors are they sitting with? What sorts of resources can we give them? And really for us, and I'm kind of going on a tangent, sorry, I just love this work.
See, I told you we weren't going to get to every single question because I knew you'd find your sweet spot. So you keep it going, Karen. We planned for this.
It's really about listening, right? And it's really about, you mentioned it earlier, like family voice and choice, right? What is the family identifying that their barriers and their needs and their wants and their desires are, and validating that and figuring out a way that we can support them in getting connected to that. So that's the approach. It's taking into consideration, culture and how is culture playing a role in the crisis and the resiliency around the crisis resolution. So, I mean, it's what we live and breathe. We used to be called Uplift Family Services, and we chose the word family for a specific reason. It's because we approach crisis from the perspective of this situation is impacting the family, and how do we support the family? So,
Karen, I hope you don't mind if I recap. As a person in a neighboring state, I'm joining from Arizona. I want to just recap some of the things that I wish my state would adopt. And then I'm going to pass it to Chris to see what we see at the systems level, if it's the gold standard, and what other promising practices are happening. So the things, Karen, love that somebody always goes out in teams. I know when I started in the field, I was responding to crisis at the middle of the night by myself, sometimes really scary. I love that you structure your support to address the person who's in need, then separately address the people who need support, then separately from that address those two things together as a complete unit that needs to work together. I love that you center the humanity of the situation, oftentimes something that's missing from our systems, and like, this is the scariest thing I could imagine happening to my child, and I'm coming in with my own set of dysregulation. And within that, I love the way you talked about the safety planning and just like the call to action for us as providers and educators to truly make them child and youth and young adult. I'm sorry to everyone using the wrong youth word, child and young adult and caregiver and family focused, and and taking the time. That's what I heard over and over again from you, Karen, was we take the time to connect, we take the time to explain, we take the time to, you know, go through this in stages, scaffolding, like educators would call it.
Yeah, crisis is inherently fast. Like everybody thinks crisis is fast, but it's not. You have to slow it down. The best crisis work happens slow, believe it or not.
Go slow to go fast. Actually, I have it right here on my I live by it, because like in equity work and crisis work, if everybody is not on the same understanding, like you can't move forward because you're leaving folks behind.
Yep.
So with that, Chris, I'm going to pass it over to you and ask, like, how has crisis care programs in your region leveraged other community-based services to address the needs of not only the person in need, the child or young adult, but the entire family unit?
Well, there's so much happening, both in California, but really nationally. I do think if there is, you know, any bright spot in what we've just gone through in the last 2.5 years, it may be that there is more attention on children and youth mental health than I think any of us have seen in decades. And so if that, you know, it is unfortunate we've had to go through this, because we had a children's mental health crisis before COVID. But I do think, you know, there is federal money to support mobile crisis in a way that hasn't happened before. There in California, we have been standing up, still being implemented, but a family urgent response system specifically for foster youth and their family members. But, you know, it will link to broader mobile crisis teams like Pacific Clinics. We are currently working on a bill that would create a new licensing category for a children's crisis residential program in California, which doesn't really exist and has been a real gap. And these children are being seen, like I said, in emergency rooms or, you know, sent to psychiatric units that are not built for children and youth. And we need to really attend to their very specific needs in order to ensure that they're not getting re-traumatized by a system that's really built for adults.
Yeah.
So there's a 988 system being stood up nationally. California is very much, you know, working on legislation around it, looking at how is that going to intersect with other efforts that are happening regionally. So that attention, I think, is really important. And I have to go back to one of the things Karen said, which feels so important to me, is that we also have to remember that every family experiences this differently through their culture, through their language, and that we have to ensure that we're attending to that, right? We're listening to what it is that's going to resonate with them. And I love the go slow to go fast, because that's where you have to start. I don't know that I really very specifically answered your question, but I do think so much of this comes back to relationship across both agencies, across individuals. You know, who do you call when you have a child that you're working with that really truly needs something now, or the family needs something now? It really comes down to not just like you said, what's the phone number I call, right? What's the 800 number
God,
I call?
I can't stand
but
that.
It's who's the person that I have that relationship with. And obviously we can't have a system built around that, but we have to make sure as community-based organizations in particular, that we are always nurturing those relationships across both the community, with faith-based organizations, with tribes, if you're not a tribal organization, you know, with organizations that work with very specific populations of children and youth, and of course with schools. Like, we haven't really talked about how critical schools are in all of this as the place where children, you know, are all found.
Are you inviting me to get on my soapbox, Chris, and talk
Yeah.
about how kids are legally required to be in an educator's presence from the hours of 8 to 5 until they reach the mandated age of compulsory education exit at age 16? And we have them all. We have them all. They're captive.
Right.
Yes.
Yes, and schools need to be one of the places where these services can be accessed. And another thing California is really attending to, right? Putting many billions of dollars into community schools and other efforts that get community-based organizations working with schools very closely.
So I so rarely have an opportunity to have a dialogue with folks in your position. So I'm going to ask a question that is not on the script. And if you don't have an answer to it, I would love to have dialogue with you later. So one of the things that's coming up a lot in my conversations are the limitation of billable services in that school-based setting. Chris, this is since you get to talk to all the behavioral health insurers organizations. But we know from a school perspective that the most effective interventions to support student mental health are those multi-tiered systems of support programs that are broadly culture and climate based and not fee for service billable typically, but Medicaid isn't structured to reimburse that way. Are you seeing any promising innovations in your region to fund those preventative services through Medicaid?
Well, the short answer is yes. I mean, California is, again, I think, leading, not without its own challenges, of course, because we are a 58 county state that does a lot of things very locally. But there is an effort called the Children and Youth Behavioral Health Initiative in California. One piece of that is bringing together managed care health plans with school districts and county offices of ed to look at ways they can partner more effectively to address some of those early interventions and prevention-oriented interventions. So the state is funding it and incentivizing those two groups to work more closely together. And of course, CBOs are also a critical part of those relationships because the problems don't end at the school door or in the school year. And you've got to get families involved and supported at the same time. So there is a lot that can be done. One of the things that we've been very recently involved in, happy to put this in the chat, is a field guide for educators that really helps them understand all of the various different initiatives in California, but also funding streams that are more sustainable through Medicaid and other services.
You actually just might have provided me some TA, Chris, because I have some educators that might like that guide in California. And thank you.
Excellent.
Love that link. Yeah. And actually, you are both leading into a question we didn't know if we were going to have time for, but I'm going to ask it because we're just going there. So what are some of, Karen, the program strengths that you've had in expanding access or providing culturally responsive care to youth? Well, you specifically mentioned your program for young adults in foster care, but do you have any other strengths or successes working with BIPOC youth, LGBTQ plus youth, or other specific populations? Chris was just talking about schools.
Yeah, we've been doing quite a bit of partnership in Santa Clara County with some of our LGBTQ wellness sites. So we have sites throughout the county in different school districts, as well as what we call our CCBHC, our healthcare clinics that incorporate physical health and mental health for children. And so we've been doing presentations, we've been doing like drop-ins. We'll have our crisis clinicians show up at some of those wellness centers and just engage kids. Part of what we like to promote is that engagement. So not necessarily just waiting for kiddos to call us or families to call us, but us making those connections with those kids. And some of the LGBTQ centers have been great places for us to make those connections with kiddos. So they're feeling safe to reach out to us. And I think we spoke to it earlier, that they know who to call, right? That they have this idea of, when I'm not feeling so well, I can call Uplift, or I can call Pacific Clinics now. The other piece that we focus on is just our hiring practices, really looking to hire staff that have lived experience. In our agencies, we call them peer support staff. So really hiring staff with lived experience that match our communities. And so we have paraprofessionals and professionals that are, responding to homes and speaking the language, understanding the culture, understanding and having experience making sense of what mental health means for different cultures. So, those are the two ways that we've had the most success. It's going out and hitting the places where the kids and young people are and making those connections, and then making sure our hiring practices reflect our community.
So again, Karen, we hear the thread line of humanity, of connection, of time for relationship. And then I'm going to connect that, Chris, to what you said earlier about the different certification programs. And so for any of our folks who are joining us from the county or state level, thinking of creative ways to do policy, to build humanness into your policy with new certifications. Can you mention it one more time? Because now I'm drawing a blank on it, but I had wrote down I wanted to ask you more about it.
Well, one of the things, and again, this is part of the Children and Youth Behavioral Health initiative in California, is work around what the state is referring to as coaches. And really they're those, they could be a peer. They could also be, when I ran school-based programs, we hired people who often were from that school community, had attended that school, really understood and had relationships with teachers and other family members and students. And so they really helped to build those relationships with what might be, a clinical team that hadn't worked in that school before. So those are critical. The other thing that is happening at the state level is a peer certification that came through a bill from last year that is very exciting, because although for many services under Medicaid, you can already bill for those services, it does, it really professionalizes and provides some consistency for those peers who want to work in the mental health system.
And just credibility to the profession. Some of the best help I've ever received is from other people who've walked in my shoes.
That's right. That's right. I mean, we know, you know, when you're working with, if you're dealing with a substance use issue, we know the success of Alcoholics Anonymous, Narcotics Anonymous. You know, these are peer-led services, but they have amazing outcomes.
Yep.
And so we've got to make sure we're integrating that.
I like that you flagged that, Chris, because in my state, and again, I'm in Arizona, we have a lot of rural and remote areas. So I don't know exactly what part of California you're in, but in some parts where we have a workforce shortage, which is what we're going to transition to, the creativity with certification and different types of certification is some of the only ways that our colleagues our friends can get support, right? And so we call them healthcare navigators, and it was a program through our tribal health services. These folks, they were just like that auntie in the community that like everybody knew where to go, and they were able to find ways to pay them as community healthcare navigators. So I think that's a really excellent example of community-driven care that can be funded and paid for, but that doesn't necessarily need a formal education, because their education is lived experience, and that's just as valuable to the treatment process. So Karen,
sometimes
Chris,
even more important.
Yeah.
Right?
Yes, actually,
yeah.
let's go ahead and revise it. They are more important to the treatment process. Our system is set up backwards. And thank you for the correction and the reminder. It's a good one for us all.
Can I get on my soapbox for one moment about something we haven't talked about?
I'd be upset if you didn't. Unpack it, Chris.
I mean, we're talking workforce shortage. I think the other thing we have to be attending to is this issue of the burden of paperwork and documentation, right? And you see it in the public systems. We have to fix this.
Yeah.
It is getting people to leave the field.
Yeah.
And who are amazing individuals, because they simply, that's not why they came to the work. They came to the work to make a difference. And we could literally double our capacity in a moment when we have a workforce shortage,
right?
And a mental health crisis and a behavioral health crisis, really, with substance use as well. And it seems like on the face of it, so simple, and yet so complicated.
Yeah.
But it's like, if we all really get at it and just make that commitment, it really feels like we could solve that problem.
Yeah. Yeah. I would just 100% jump on that soapbox with you. You know, the amount of documentation that my team has to do when they go out and do, you know, a 3 or 4 hour crisis response, which we all know the intensity of that service and what it feels like to walk out of a crisis, you know, as a individual supporting a child or family, and know in the back of your mind you've got another 2 hours of paperwork to do. I mean, I just am on your soapbox as well. I hope that, and I'm glad to hear that that you from your chair are championing that, because it's the number one thing that I hear from my teams. You know, it's, believe it or not, it's not the work.
It's not, it's never the work. It's never the work.
Yeah. I mean, people come to crisis because they love crisis. It means something to them, but it really is that burden that you spoke about that makes staying in the position unsustainable and unappealing for new people coming in.
Yeah.
Chris, I think this radical notion that we need to just overhaul the way we fund it, because that's ultimately a fee for, like, that's ultimately tied to a fee for service, and you're having the burden of proving what you did for the amount of time that that service was. So like, I mean, yeah, my documentation was ridiculous. One of the reasons I left the mental health field and stayed in education, by the way, if anyone's listening, who could have an ability to change that, because I was spending so much time on, and I'm going to say this because I don't work in the mental health field anymore, what ultimately ended up to be creative copy and pasting, because the burden of paperwork was so high that I could never have written anything meaningful for the caseload that I was carrying.
Yeah.
And I don't know if people who are currently employed in the mental health field have the freedom to say that, but I am not. So I will say it for them. There is no way someone can write what is actually happening and meaningfully and still do their job.
Right.
Woo! Louder for the people in the back, Chris. All right. So what are some trends that you have identified in terms of recruitment, hiring, and retention of crisis care staff, specifically ones that are providing services to children, young adults, and their families and caregivers?
Well, I'll tell you the shift that we've been navigating right now is retention, because the recruitment is challenging. We've really focused on retention and addressing, and this was another question that was on there, but just addressing burnout, making sure our staff are well supported, they're cared for. That same, I love the word nurturing. I never really thought of it that way, but that same approach with our staff, and at some level from my chair, setting some limits on what resources we actually have in the boat, and what we can realistically provide to the community. We've got clinicians that'll, in an 8 or 10 hour shift, they'll do 4 crisis responses, and the 5th call will come. I know the 5th call will come in and we have to say, no, we don't have the resources to send somebody. We've got to do stabilization over the phone. We've got to look at another program. We got to access their current service provider, because the need is just is outweighing the resources right now. And then there's been lots of great, Santa Clara County has launched some, tuition reimbursement programs that have been really great. Hiring incentives, we've done that. But also the model, and Yasmin, you spoke a little bit of it, shifting away from this idea that the clinician has to be the one that's kind of driving care, but our staff with lived experience, our peer specialists, as we call them, our crisis intervention specialists, bachelor's level or even non-bachelor's level staff, like they work magic on crisis calls. And that this idea that every crisis call has to have a clinician present, really pushing back on that notion that lots of people can do this work, and it's a misnomer that there always has to be a clinician available. So I know, Chris, you've got a perspective as well, but that's kind of where we're sitting.
I couldn't agree with you more, Karen. When I think back, to my work as a provider, and I think, who are the best people at managing a child in crisis? It wasn't necessarily the clinician. It really was someone who just had those traits, that skill of relating at the young person's level, right?
Yep.
Like really having them feel that they were there with them. And you don't learn that just by getting a master's degree.
It's I was on a panel recently with some folks who were survivors of the criminal justice system. They'd served time in prison, and the gentleman who's on the panel with me, he got out his soapbox and he said, I have a PhD in lived experience. I'm going to start putting it on my resume and asking to be paid for that PhD in lived experience, because what I know cannot be taught in a school or by a book.
Yep.
And you can't do it without me.
I love it.
And it
That's
just was
fantastic.
like, oh, I almost fell out of my chair.
Yeah.
Wow. That's,
So if
let's
we have any
end there.
yeah, like if we have any peers on the call, you have our collective permission to say you have a PhD in lived experience, and then ask for pay commensurate. And actually, Chris, I do think we get to end there because, and drop the mic, now we get the ultra exciting part to offer it up to the people who are here with us to ask questions of these two remarkable individuals. And if you don't know that, I've got like 5 written down that came up, but this isn't about me, this is about us learning together. So what do you want to know from Chris and Karen from what you heard?
Well, our peer certification, I think, probably is pretty close.
Yeah.
And this development of looking at a coach role through our Children and Youth Behavioral Health Initiative is also, I think, specifically to work in schools is the idea. And so I think we're trying to look at a varied way of doing that. But certainly it follows along that healthcare worker, community healthcare worker model.
Mm-hmm.
Taylor asks, I'm curious to know how your programs that take crisis calls deal with calls that are not a suicidal crisis. Sometimes we get calls from people who just want to talk, or kids that can't get services because the parent won't consent. Karen, from your program perspective, and then Chris from a systems perspective, to things you've seen work.
Yeah, we get calls frequently from kids that are not suicidal, and we actually even do mobile responses for kids that are not suicidal. So just because there's and this was a recent expansion in our contract, if there's a kid that's just struggling, whatever that might look like, if they're needing someone to talk to either in person or over the phone, we can send a team out, or we can send one person out to support that kid. We do a lot of that stabilization over the phone as well. We have that option. The nice thing about our mobile crisis program is we actually have a 30-day follow-up window. So we can follow up with children and families 30 days post-service. So if it's a kid that's calling and maybe they do want support with getting connected with services, but the parents aren't consenting, but the child is open for us to talk to the parent or caregiver, we can navigate that with our service structure. I'm not sure I answered your question directly or not. I guess the short end of it is we can respond to a variety of crises. Sometimes we coach our new staff to say the crisis is defined by the caller, not us. So if the person is identifying that they're in crisis, which might not necessarily be that they're feeling suicidal, for them it's a crisis, and for us that's something we support.
Oh, I love that little just person-centered shift in the values of what crisis even means.
Yeah.
And just an important reminder that, like, wow, as professionals, crisis might mean something totally different for us. And, and also as adults with fully developed prefrontal cortex.
Yep.
Ooh,
Well,
that's my takeaway.
I think Taylor's bringing up another important issue. Well, multiple different important issues. One is that issue of consent, but also the issue of if we don't ensure, like you can't look at just crisis services in a silo, right? If we don't ensure that we have enough of all the levels of service that children and youth need, we're going to end up with a whole lot more calling those crisis lines because they can't, they can't access a therapist or they can't access a counselor. And so we have to make sure that we're really getting the whole system right. We are working in California on a virtual platform that would provide not only education, but access to services across the state. And I've been sitting on the work group. It's been very fascinating to both learn about sort of the technology available and how we can integrate that, but also how important it is that that's not the answer if you don't have all the other services available,
Right.
whether it's in person or locally, or the crisis services like Pacific Clinics provides. So you really have to look at the system as a whole, I guess is my
I think that's the hard and the easy part of it, and also the part of the big picture question that we have the joy and the sadness of leaving you with today is the thread line of it all is an attention to humanness, Karen, and modifying our systems to be person-centered and healing focused. And we can do that with the systems that we have. I heard that in the way that we changed the definition of crisis. The crisis is defined by the caller and not for us. I heard throughout our time today a call for a need for us to re-examine the fee-for-service models that are creating burdensome paperwork and honestly causing our field workforce retention issues in a time of workforce shortage, where we could double our human capacity by reducing the paperwork burden on the people already in it and create more incentive for the ones who are already here to stay because they have more time to do what it is they like, which is connect with people and help them through those difficult moments of their lives and show them hope.
Thanks, everybody.
Thank you.
Thanks, everyone. Take care.